Good morning, everyone, and welcome to Within's Continuing Education webinar. My name is Ashley Barkoviak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I would like to introduce you to my colleague, Ronnie Lee. Ronnie recently graduated with his doctorate in psychology, and we are so grateful to have him here as one of our primary therapists here at Within Health. Today, he will be presenting on the topic, a clinical overview of radically open DBT, an introduction to skill building and identification of appropriateness for treatment. Before we start the CEU, I want to introduce Jamie Singletary. She'll be explaining a little bit more on how to receive those credits and where to go for that information. Jamie, go ahead.
Thank you, Ashley. Hello, everyone, and thank you so much for joining us today for our CE presentation. As Ashley mentioned, I just want to go over a few housekeeping things when obtaining your certificate. So at the completion of the webinar, you will receive an evaluation to the email that you registered for the CE presentation with. Once you complete that evaluation, you will then receive a link to the same email to be able to download your certificate. We will also have a recording of this presentation available to you if you have registered for this presentation. If you are registered and you want to go back and watch it, you're welcome to do so. If you are registered but you are missing the presentation live, you will not be able to receive CE credit for watching the video presentation. My email address will be available in the chat. If you have any questions or any concerns about how to obtain your CE certificate, please don't hesitate to email me. And if for any chance you have to change devices or you have technology issues, we will also be able to make sure that you get your CE credit. Thank you so much, and I hope you enjoy our talk today.
And Ronnie, we're ready for you whenever you're ready.
All righty, let's go ahead and get started. Thank you so much, Ashley and Jamie. I really appreciate it. I'm super happy to be here, first and foremost, because I'm typically on the other side of these CE talks. So to be able to be on this side is a lot of fun, number one. And number two, because I truly am passionate about RO-DBT. I'm still very new, of course, to the field and to this modality, but for me, it makes a lot of sense with the population that I work with, being eating disorders, and just makes a lot of sense to me in general. So I'm happy to share some of my insights with you as we get started. Right. Okay. So the talk today is called Moving from Rigidity to Resilience, Radically Open Dialectical Behavior Therapy. And we're going to go through quite a few things today. So this talk may be or may need to be broken up into 2 or 3 parts. Hopefully I do a great job today and I can come back. I'm invited back. But I really want to try to touch on quite a few things, mainly what is the purpose of RO-DBT, right? I think that we hear about RO-DBT quite a bit, especially nowadays. It's something that is infused in a lot of treatment centers, but what exactly is it? What does it entail? What is the focus? What is the preferred population for this modality? We'll also talk a little bit about research, not too much, but just get our feet wet into how this all came about. Definitely want to touch on assessment as well. I think that that's a big part in making sure that we have the correct diagnoses and the correct personality traits to administer a treatment like this. And then lastly, I want to just quickly introduce you all to 2 or 3 RO-DBT skills that I find extremely useful and I think really lay the groundwork or framework for RO-DBT as a whole, okay? The majority of the information that you'll see on my slides, they come from a variety of different resources, most notably the RO-DBT skills manual, of course. Derive a lot of information from that, also from various research articles that have been published by Dr. Thomas Lynch and his team, as well as other researchers as well. And I'll have everything cited so you can see them appropriately. And then also www.radicallyopendbt.net is another great resource for myself. So let's get started. And what talk is started without a quote, and I will read this one. In RO-DBT, silliness is no laughing matter. Our over-controlled clients are already too serious. They compulsively work and strive to achieve long-term goals, yet have forgotten how to relax, play, or join in with others. For an over-controlled client, socializing can feel like hard work. So I could have chosen really any quote, right? I mean, there's so many great things in the RO-DBT manual and throughout the various resources. But for me, I think that this one stands out the most, and particularly that first sentence. In RO-DBT, silliness is no laughing matter. And if there's anything that you pull from this talk, I really hope that silliness and just the inner joy that we all have, that's one of the core mechanisms of why RO-DBT is successful. We pull so much from our own personality, our own silliness, our own flares. And if you see myself or Danielle Gordon and RO-DBT group, I hope that you see that is our genuine silly self, and we joke around a lot between each other and with the clients in there, and we're attempting to model that it's okay to open up, it's okay to be a little bit silly, right? It's okay to have that innocent curiosity and show a side of us that maybe as we're getting older and in society, we feel that it may be necessary to hide. And with that being said, I mentioned Danielle Gordon. I don't know if Danielle's here. I can't say enough great things about Danielle, who was the co-facilitator with me in RO-DBT. So if you don't know who she is, you will definitely very soon, because of the great work that she's doing, not only in RO-DBT, but also in DBT with our RFID clients and across the board. So thank you so much to Danielle. All right. Okay. Why RO-DBT? So to answer this question, we'll travel back a little bit to the early 2000s. I think 2000, I was like in second grade. So all of this stuff was happening and I had no idea. But if I was cognizant then, I would have been amazed with all of the early research that Dr. Lynch and his team were conducting. So around this time, and again, psychology, it looked very different at that time, right? We're still compiling a lot of research and data and understanding diagnoses and restructuring the DSM in many different ways. But most of the research, not only in the early 2000s, but into the middle 2000s, focused on what we would call our under-controlled personality disorder. So this number I have here is 95%. That's specifically from a resource. I can't confirm that. I think it would vary quite a bit, but I'll say generally 90 to 95% of the research at this time focused on under-controlled disorders, such as borderline personality disorder, right? And if we kind of like analyze that a bit more, it makes sense, right? It makes complete sense. Why? Well, because those under-controlled personality disorders and under-controlled disorders in general are more externalizing, right? So they are more treatment-seeking for the most part, right? Their distress is shown to quite a few people. So as mental health providers and healthcare workers, of course, that's where the focus was. However, the interesting thing is the community at large, it doesn't necessarily replicate that, right? We see more over-controlled personality disorders. And when I say personality disorders, I really mean traits, personality traits, right? So traits from OCPD, right? Traits from PPD, and also traits from avoidant personality disorder as well. I don't want to speak for Dr. Thomas Lynch, but I think that he looked at some of these factors and said, okay, well, there's there's some lapse in research here. I wonder what does the chronicity and the maladaptive behaviors of our over-controlled individuals look like, right? And what are we missing? There's also a second piece here. So not only, was the majority of research focused on under-controlled, but these studies conducted were, and again, I'm generalizing here, but the majority of studies conducted were very specific presentations, right? So the question was, if we look around at our population, we see more chronicity than not when it comes to mental health and more comorbidities, right? And definitely in the past decade, I think that is true. And with myself and my team, it's be very rare for us to receive a client who doesn't have, other comorbid diagnoses or traits to consider. So the idea is, not only do we want to look at more of our over-controlled clients, and I'll talk a little bit more about what I mean by that, but also over-controlled with more chronic presentation, and then with more comorbidities, excuse me. And then there's just a small graphic here with just some values. Comorbidities. I just want to put this up quickly. I got this directly from the skills manual. It just looks at different disorders that we would classify as under control or over control. So on the left, we have, we all know borderline personality disorder, one, bipolar disorder, binge purge eating disorders, externalizing disorders as well. So these are all kind of like our hallmark under control. And on the right, we have OCPD, of course. And if we kind of like take a snapshot of that criteria, it checks off a lot of the boxes of what we would consider over control. Anorexia nervosa as well. And then more recently, autism spectrum disorders are starting to gain a lot of traction treatment-wise. And then also internalizing disorders. And again, when I say externalizing versus internalizing, I know many of you know this, but externalizing being where it is more observed, right? So the behavior is more visible, right? And at times possibly more harmful, but not always. And we'll touch on that a bit later. And also let me add, I'm going to be doing a lot of comparing and contrasting. I think we all know that mental health is not so black and white, but we are really focused on kind of like the ends of the spectrum. There's an awesome graphic that I just didn't have the ability to put on my slides because of copyright, but there's a graphic that shows kind of the majority of people kind of function in this spectrum between over-controlled and under-controlled, right? So we're not necessarily focused with those. We're really talking about the extremes here, okay? So yeah, we talked a little bit about, why RO-DBT, why it was even a thought. And so for the need of RO-DBT, we can take a look at some of the research. And I will not be spending a ton of time here because I don't have a ton of time with you all, but also, I think that there's some other things that we can get to that are a little bit better served. But I will add, obviously that this was created specifically to treat maladaptive over-control tendencies, okay, and traits. It has been informed by over 20 plus years of research, edging toward 30 years, and then over 350 plus patients have received RO-DBT in research trials. I broke it up, or Dr. Lynch breaks it up in 4 different categories. So the early RO-DBT research was really focused on trying to apply DBT to the over-controlled population. What he found is that it just was not working, right? It wasn't as effective as he thought. There were certain skills that were as effective, but as a whole, the protocol was not. And we can understand why that is. Circa 2007, the research focused on refractory depression and what that looked like in different populations, and also including in his biosocial theory of over control. 2015 and 2018, this is where things really started to get moving. I think probably in the United States, RO-DBT was more of a mainstay. It had taken off previously in the UK, but it's safe to say around this time, it's gained more traction here. And a lot of the research was focused on just replicating previous data, doing more randomized controls with the manual, and generalizability as well. Okay. And then currently there's many different current research studies going on. I mentioned previously autism spectrum disorders is really at the forefront of some of these, of course, eating disorders as well, and so on and so forth. So that's about all I'll say research-wise. If you have any specific questions, please feel free to reach out to me. I won't put my email in the chat, but at the end, I will give you all my email, and Ashley, feel free to put it in the chat, so anybody can reach out. This seemed much larger to me, the bottom right here, when I put my slides together, but it is tiny. What they are 5, I thought really cool RO-DBT studies focused on eating disorders. It ranges from, I think, 2020 all the way back to 2014 or 2013, one of them. And I found these to be very useful. Again, we could probably do a whole talk just focused on this. But if you want to, if you can see it, I don't even know if you can see it, but please take those article titles down and enjoy. All right, general treatment structure. If you take a look at this, like from a snapshot, it looks very similar to DBT, right? It's a few tweaks there, like few value changes, but in general, RO-DBT has 1 hour per week individual session, outpatient skills training class, 2.5 hours per week. There's telephone consultation, very similar to DBT, and then clinician consultation as well. The treatment sessions are broken down, and the first 5 really orientation, just commitment to the modality. RO skills training begins week 3 and continues until week 30, and then session 5 is really when the targeted symptoms start to take place. Primary targets, again, directly from the manual: decreased behavioral over control, aloofness and emotional loneliness, right? Not so much social loneliness. So I think that I want to make a point there. You know, there are some over-controlled individuals who are not socially lonely, right? They do have interpersonal connections. They do have families, right? They do have people that they find very close to themselves and their social support system. But if we examine that a bit more, we'll see more emotional loneliness, right? Also, the primary target is to increase behavioral flexibility, right? Want to be more flexible. We always talk about this term rigidity, especially with certain eating disorder presentations, wanting to increase that flexibility, openness, and emotional expression as well. And then lastly, overall, more socially connected, not only with the individuals that we feel comfortable with, but just a general community, social connectedness. We find that is extremely helpful. And then I just added some of the RO skills training lessons. Well, not some of them, all 30 are here. If you just take a glance at these, a lot of what you see is RO-DBT infused with good old-fashioned DBT, right? Because let's be honest, Marsha Linehan and that team has done amazing work, not only for the treatment of certain presentations, but for the field of mental health, right? So it would be a shame not to include many of these, and we really take a lot of what DBT has infused, especially skill-wise, and lend that in our groups as well. And this is really what Danielle and I follow to the T. You know, if there's anybody in the audience now that is trained in RO-DBT and practices it, you may be cringing at the fact that we are not utilizing 2.5 hours a week, and there isn't concurrent individual therapy. Right now, that just isn't feasible for our treatment at the moment. But I will say that Danielle and I typically spend about 2 sessions per training skill session, right? So it would just be way too much to cram into 45 minutes. So over the course of 2 weeks, we will talk about radical openness, right? Especially activating social safety. There's a group that really goes into depth with our neuroregulatory systems and kind of understanding, you know, what each of those mean. And it's actually like very content heavy, right? So to do that in 45 minutes would be near impossible. So yeah, we definitely stick to these as best as we can. All right, finally, I honestly, I probably should have put this slide a bit earlier because I've used over-controlled and under-controlled so much. And also this picture just makes me laugh. I was debating like, should I put it on there? Of course, not every over-controlled client is this observant of details, but this picture made me laugh and giggle. So I kept it. As you can probably already gather, under control refers to our impulsive presentations, right? Dramatic, emotionally expressive individuals, and these are more likely to come to fruition in our externalizing ways, so externalizing disorders. And sometimes they don't necessarily meet criteria for a specific disorder, right? But they're just a symptomatology, right? More externalizing. And then contrary, over-controlled, which is going to be the focus of today's talk. These are individuals who are emotionally constricted, shy, risk-averse, socially anxious individuals, and they're more likely to develop these internalizing disorders and become socially isolated adults. And of course, depression and anxiety, they can also be externalizing, but when we talk about them today, we're going to talk about the internalizing presentation of both depression and anxiety. And as we're working through these slides, I encourage you, no matter the discipline, if you can think about a client that you're currently seeing, or a client that you've seen in the past or have sat in with in the past that meets some of the over-controlled traits, I encourage you to think about their presentation as I'm working through some of these slides. I think sometimes it's helpful to have kind of the picture in our mind already, and be able to kind of like tease apart, oh, okay, like is this individual more over-controlled, or can they be classified as such? And I'll get a little bit more in depth into what it means to actually classify them here in a bit. Okay, so why is over-control so bad, right? Well, why is it maladaptive? You can make an argument that over-control is adaptive in many settings, many points in our life, and yes, that would be true, right? I said this before, that when I was going through grad school, and anybody who had any extra training or like higher level training, you know that a lot of those like programs are set up like for you to be over controlled. You have to be over controlled in some way, right? And I remember back to that time where everything, my grades had to be this way so I could get into these classes, so I could get to this practicum, and if I do that practicum, that'll get me to this practicum, and that will get me into APA accredited internship, and then that will get me into a APA accredited postdoc. And it's this like very methodical way of thinking, and like everything had to be measured down to the T, right? Almost like this guy here, measuring the grass. But luckily, I had people around me say, hey, Ronnie, you know, maybe take a step back, maybe take a breath. And I was able, or I hope so, to balance some of the over control, right? And I think that that's a good description of somebody typically who can go back and forth, right? Sometimes in our life, we have to be a little bit more over controlled, right? Whether it be family related, whether it be work related, education related. It's something that could be adaptive. But I think the key, right? The key is, are you able to have the insight to understand when it turns maladaptive, right? Would be one key. And then the other key would be, you know, are we able to kind of oscillate between like in that lull area, right? So of course, there is healthy control, but when it is the primary source of functioning with many things in mental health, with many symptoms, it can turn maladaptive very quickly. Well, I say very quickly, but it's more of an insidious rise than like acute. Of course, it's linked to various chronic mental health symptoms and diagnoses. We just went over a whole list of them. And so to explain this like a bit more, you know, like why are some people more over-controlled versus under-controlled, versus able to oscillate in between? It's this idea of biotemperament. So this is a very superficial description of it. It's far more in depth than I'm about to describe, but I hope it gives you just a little bit of what biotemperament means. So it's just the idea that there's both a genetic and biological predisposition that impacts how we perceive the world, of course, and how we feel that we have to regulate our emotions from our perception of the world, okay? Of course, there are more things that go into it. The whole idea of like biopsychosocial also plays a role, and then also just, you know, kind of the coping skills that we were taught as well. So this is a graphic. I pulled this from the website that talks about nature nurture and also our coping. So in other words, biopsychosocial. Of course, you know, depending on our depending on how we're able to adapt and modify, so typically it happens on a preconscious level, right? So we're not easily, or individuals who are more over controlled, they find it very difficult to interrupt their cycle, right? To interrupt and adapt and to change, right? And that's where that rigidity comes from. But it's not so much this effortful act as it is just a preconscious, almost reflexive behavior, right? Or thought process as well. Okay, so as we transition into the second part of today's talk, I wanna read this short story, Hunting Dogs, Swords, and Shields. And this is something that myself and Danielle will do. This is, I think, like the third or fourth like skill group where we will read this with our group and kind of go over it together. It is it follows the skills training protocol. And I just want to give you a glimpse into one of these stories, because there's a lot of these really, really amazing and elaborate stories that are infused within the protocol that I think, you know, is able to be a helpful metaphor for individuals who are struggling with some of the insight. Okay. There once was a man who believed no one liked him. His friend said, just go to the village and spend time in the square. You will see that none avoid you. The man said, you don't understand. People really hate me. They look at me as if something is wrong with me. I don't see how this would work. Finally, his friend convinced him to try, and so he did. The next week, his friend asked, how did it go at the village? The man replied, I did just as you said. I went to the village with my 3 hunting dogs, restrained, of course, my shield on my back and my sword in my belt. You can never be too cautious. What might you think happened? The mothers in the village picked up their children and took them inside. The fathers glared at me with contempt, and not a soul came to speak to me on the bench. I sat on it in the center of the square. My dogs weren't even barking that much. And you think people like me? So it would be right around this time, if I was able, I would ask you all, what does this story mean to you? I typically get various responses. But at the end of the day, you know, to speed things up, it comes down to just what the metaphors of swords, shields, and hunting dogs mean. And those are the things that we utilize to protect ourselves, right? So this isn't RO-DBT specific, right? We can use this really for any modality or any theory that we want to conceptualize with, right? It's not new, but I think it helps with gaining insight. Okay, what are those shields and swords that we use on a daily basis, right? What do we utilize, or what do we thrust ourselves in to protect ourselves from feeling certain emotions, or from having people come close to us, right? And I want you, if you have a client in mind, you know, a couple slides ago, I asked you to think about one who may fit this presentation. I encourage you to think about what are their shields? What are their swords? I definitely have one in mind. You know, and for them, it's all academic achievement. You know, a brilliant individual, but everything is related to the academics, right? And for them, their academics, that is their shield. That is their sword, right? Every conversation goes back to academics. Why is that, right? And I think that's a good place, a great place to conceptualize. All right, so the second part, let's see how I'm doing on time. Manageable. I'll make it work. Deficits of over control. So this isn't something that is just thought of, right? It's actual research that have identified these 4 major deficits, right? So the first one, receptivity and openness, you know, which is one of the main points, obviously, of radically open DBT. It is the ability to be open to receive feedback, not only feedback as it relates to like constructive criticism, but also just feedback on their overall functioning, right? Secondly, flexible responding. So I think there's, you know, many different definitions of this, but for me, the one that makes sense the most is, you know, thinking about if you're in a novel situation or in a novel context, you know, are you able to adapt? And I think that this, you know, I could put an asterisk by that one, because I think that's difficult in general, right? I think even individuals who are more outgoing, it's hard, right? If you're in a new context and there's new people around you, it's hard to be able to kind of identify and to have the cognitive flexibility as well to adapt to that situation, right? Also deficits in emotional expression and awareness, for sure. It's something that we want to increase their ability to express themselves emotionally, because we do see something called emotional leakage if that does not occur. And then lastly, social connectedness and intimacy. And so, you know, I think another way to look at the treatment of RO-DBT is like through the lens of these 4. You know, where are the deficits in your client? Which ones are most glaring? Which ones have a little bit of traction? I really enjoy Harry Potter, always have. And I think about like Hermione Granger, And this is going to make no sense to you if you aren't aware of what happened in Harry Potter. But if you do, then Hermione Granger, she definitely fits the mold of an over-controlled presentation, right? Very flexible, inflexible thinking, very specific, structured, everything, there's a reason for everything. But for her, the social connectedness and intimacy piece, that is what opened the door to these other things, right? She found the community of her friends, right? And then she goes into the Forbidden Library and the Forbidden Forest and all these things that, probably Hermione herself would never do. So I use that example, kind of a silly example, because I don't think that there's a right focus when you start, but I think it could be helpful to identify, which of these doors may already be unlocked, right? And kind of work through that lens a little bit. Let's see, where are we at? Okay. Social signaling. So this kind of relates back to my story. Oh, where are we at? The hunting dogs, swords, and shields, right? So he signaled to the square that I am not approachable, right? I have all of this like armor and shield and metal around me, not approachable, right? And the idea of social signaling is we actually have kind of this innate ability to give off certain nonverbals to others, right? To kind of allow them to see that we are a bit more receptive, a bit more open. This photo here is just a stock photo that came with the side by. I was working like through it. I was like, oh, this individual looks very inviting, like happy and relaxed and open. We can infer all of these things from their nonverbals, right? And I think like that is the piece sometimes that is missing, right, with our over-controlled clients, is that they are kind of perpetually stuck in this overwhelmed / threatened neuroregulatory system, right? Where the sympathetic nervous system is like constantly firing, constantly on edge. And you see that in their face a lot, right? A lot of times, again, generalizing here, but a lot of times the clients who really do fit the criteria for over-controlled traits, they can be quite expressionless, right? Almost like mask-like. And it is their body's way of saying, I don't know exactly what's going on. I don't know if I can really let my guard down, right? And then this becomes a lifestyle, right? It becomes a day-to-day functioning. It becomes personality as well. And there's a really famous, well, I think it's really famous skill in RO-DBT called Big 3+1 that directly aims at shifting our neuroregulatory system from one that is more threatened, more overwhelmed, to more that is more safe, right? So we want to elicit more social safety, and there's different ways to do that. And one of them is the Big 3+1, which we'll get to a little bit later. But yeah, so non-mood dependent versus mood dependent, private versus public displays of emotion, low variability high versus high ability. These are all things that are kind of like wrapped up in what we are signaling socially on a day-to-day basis. Also, let me add this. This isn't to say that we should just encourage our clients to just walk around and be completely aloof, all over the place. I live here in Houston, and I'm always walking around downtown and different like shops and cafes. And there's many times, right, where I have my headphones in, and there's no smile. Like I don't want any interaction. It's early in the morning, right? Or so these things are obviously okay as well. But again, it's about having the flexibility to elicit that social safety, the flexibility to give off these social signaling that we are open, we are receptive. Don't be fooled. As clinicians, as mental health workers, as any discipline, right? It may be very easy for this presentation to fool us, right? Because they are working in overdrive to compartmentalize their emotions. They are pros at hiding their emotions. Why? Because it's been adaptive for them, right? It's been reinforcing, like many symptoms that become maladaptive. At some point, it is reinforcing, right? It just so happens that with our over-controlled plans, it has been adaptive for a very long period of time, right? So their motivation to appear competent, to appear fine, hey, I'm okay. They are professionals at this. I can't stress it enough. But it is our job, it is our duty to dig a little bit deeper, right? You know, people don't just stumble into certain types of treatment settings, right? It's not something that you just like wake up and, oh, I'll check this out. No, it takes a long time to get there. It takes a lot of answering questions. So, you know, if you have somebody who does have this presentation about them, and we're like, oh, you know, I'm all good, no worries. Your eyebrows should be raised, right? And that should be a good indication. Like, okay, you know, there's some assessment to be done here. Emotional leakage. I brought this term up a bit earlier. I think that it explains what happens when we constrict our emotions too much. I think it explains it very well. Again, a very superficial explanation, but basically it's the spillover that can happen when we constrict our emotions for far too long. So you may say, or some may say, wow, like that reaction did not match the magnitude of the stimulus that caused it, which is true. And also true actually, just in general, but specifically for this presentation, it is very true, right? So what you'll find is that, you know, whenever there's an outlet for it, even if it's a small one, that's where we see that emotional, it just kind of like leaks out, right? So an example would be like if your neighbor, right, walked their dogs 3, 4, like German Shepherds every day, and they stopped in your lawn or your area and went to the bathroom, right, every day. And you don't say anything for like a year. You just pick it up, right? And you're just like inside, you're furious, but you don't say anything. You don't report them, you don't do anything. But they come over, right? And like ask for something or invite you to a cookout. And you say, no, like get off of my lawn before I call the police, and you slam the door in their face, right? It's that emotional leakage from all of the emotional constriction that they've had built up, right? And that was a very specific example where there was like a primary reason for that. But there's also the idea that emotional leakage can occur when there's no specific stimulus as well, right? So this just can be like anger or resentment toward individuals or toward corporations, right? Or put in like more emotional energy into maybe things or like volunteer things that, of course, may warrant it, but kind of like a curious amount of emotional energy. Like, oh, okay, you don't put this much emotional energy into yourself or to your family, but you're really passionate about like this thing here. So, all right. Suicide and self-harm. I got a lot of this from Dr. Allison Donovan at the Melrose Center, doing great work over there. I'm not going to spend too much time here, but basically under control versus over control, suicide and self-harm, there's a lot of overlap, right? Namely, there's high rates in both, right? Our under controlled individuals, they're just a bit more mood dependent, unplanned, typically done in areas that can be easily seen. Our overcontrolled individuals are still at the same high rates, less gestures, less suicidal gestures, but same rates self-harm-wise, typically more planned, more rule-governed versus mood-governed, right? So if this occurs, then I will, or therefore I will act, and this can be planned weeks out as well. So assessment-wise, you know, and I'm gonna go on a little bit of a rant here. I think as mental health professionals and clinicians in general, we have a duty to assess thoroughly, right? And when I say assess, I don't mean, you know, like a long battery of tests or anything like that, but we have the ability to utilize questionnaires, different assessments, to really reinforce our diagnosis, to reinforce our conceptualization. And I think that it's a necessity, right? I think far too often we just utilize our own clinical ability. And I think in many cases, you know, that's enough. But to go the extra step and to reinforce it, I think is super important, right? So utilizing the questionnaires and the checklists that have research, you know, decades of research behind it, right? Just to have a bit more strong foundation. So when individuals do come to see us, we're able to say, oh, okay, you know, I see this diagnosis, but let me clarify this, right? Or there's, you know, there's endorsed difficulty sleeping. You know, it sounds like insomnia, but I'm not sure. You know, rather than not being sure, let's utilize the ISI, the Insomnia Severity Index, right? Let's see what the score actually is, and then let's let that guide our treatment. So I say all of that to say that RO-DBT has this kind of like structured pattern for assessments, which I find really refreshing. I think that it's great. And then on the left here is just some of the things to keep in mind as we were assessing. On the right, we'll start with the word pair checklist. So this is, you know, not specific to RO-DBT. You've probably seen this before, but two columns, right? So you just circle, you know, which one you feel a little bit more in line with, and then we add up the totals at the end. Obviously, one is under controlled, one is over controlled. And then that'll give you a good take, especially if they're all scattered. That'll let you know maybe there's something else going on here versus then like a clear cut over control. Let's see, the PNS, the personal need for structure. I don't have the rights to post it, so I like changed up the language a little bit, so it looks something like this. So just, for example, number 5, I like being spontaneous. Number 7, I do not like situations that are uncertain. 11, I enjoy the exhilaration of being in unpredictable situations. So it just kind of like lends more over controlled or under control. And then lastly here, our relevant questionnaire is the acceptance and action questionnaire, which I do have the PDF right here. I also think, you know, when we're providing these assessments, it's important to make sure that they don't feel that it is like an indication of how they're doing overall, right? So, you know, I think motivation and you know, structuring of scores, we should be mindful with all clients, but specifically, you know, these, because I think, you know, there's times where they can feel like, okay, I need to try to get the perfect score, or I need to try to make sure that this doesn't read a certain way. So like really taking the time and going through the questions with them versus just giving to them, I think can be very helpful. And the next step is our clinical interview. We want to assess the diagnoses that have come in, that they have come in with, and use supplemental questions for that. So I think the diagnosis portion is particularly useful, especially if we have somebody come in with something like OCPD. Of course, they check a lot of the boxes for over control, but that isn't always the correct diagnosis, right? There could be other things. So being a good clinician and detective there, and just digging a little bit deeper and really trying to identify, okay, does this fit? And here are some supplemental questions. Again, feel free to reach out to me on email, and I can provide any of these to you. Right. And then the two on the bottom, because of time, I'm not going to go over them too much. But the first one is over-controlled global prototype rating scale, and then also the clinician rated over-controlled trait scale. Right. Where are we at? Okay. I'm going to do about 5 more minutes and then save 5 minutes for questions. That may not be enough for questions, but we'll see. So RO skills training, this is, again, as I mentioned, what we are doing in our groups. The focus is truly on educating and increasing insight. It's not so much on the healing, right? Because it is a group setting, and it's really just on reinforcing their ability to work through some of these skills. As facilitators, as I mentioned, enthusiasm, passion, curiosity, these are all things that are just necessary, right? I talk about Danielle and how amazing she is, and I really believe that clients can see that, right? And there's so many great primary therapists here at Within Health, Kate, Lorena, Ali, Cheryl, Mana, that the list goes on and on, that just fit this mold of enthusiastic, passionate, curious, and I think that our clients really can tell the difference. So we want to model that behavior. And then, yeah, there's like a hierarchy that we want to set the training classes up, but I'm going to skip that for now because I do want to get to at least some of the skills. Like, I've talked so much about skills and how great it is and all of these things, but I haven't really given you anything. So one of the first skills that we teach is flexible mind. Definitely not to be confused with flexible mind adopts, but definitely aims at acknowledging distress, using self-inquiry to learn, and then flexibly responding with humility. Acknowledging the distress is the first step. Typically, our over-controlled clients don't even get here, right? Because they feel the distress, and boom, they're gone. Right. So allowing them to acknowledge the distress, making sure that they feel comfortable and safe doing so, using self-inquiry, another major skill here. And this is a place where we want to inquire about why we feel a certain way, why we are wanting to distract so quickly. I always give the example, it's like a young kid. I don't have children, but I imagine young kids, they say why a lot, right? It's like, oh, the spaceship launched off. Why? Also, there would be more space exploration. Well, why? Oh, just so we can see if there's any other resources out there. Well, why? And we kind of lose that self-inquiry as we get older. So it's really about bringing that back and starting to question our own behavior, right? So there's some accountability in there as well. I'll just quickly, this is myths on the left, so myths about the ways that we function, and then some self-inquiry questions on the right. So I'll read from the right here. Second bullet point, what might this myth be telling me about myself and my life? The fifth bullet point, what might my resistance to changing this myth be telling me? And the last one is, there something to learn from my resistance? So the self-inquiry questions go on for forever. I think they're really useful. And again, it's to inquire about our day-to-day functioning, right? Let's analyze it. The last thing I'll touch on, because of time, there's much more to touch on, but is our big 3+1 skill. I think probably the most famous with RO-DBT. So this is directly aimed to activate our social safety neuroregulatory system. And there's research that shows that it does work. It is useful. And it really takes a lot of, this isn't brand new stuff, right? We've been doing somatic work for a long time in this field. So the way it goes is I'll ask my clients, to lean back in their chair, find a comfortable slouching position, and tell yourself, I'm chilled out, I'm chilling. You take a slow, deep breath, no counting, just a slow breath, whatever is comfortable for you. Having a closed mouth smile with the ends of your mouth slightly going up, not exaggerated, but just slightly going up. And then lastly, an eyebrow wag, raising both eyebrows, again, slightly, right? Very similar to the picture. So a nice gentle smile, raising the eyebrows, slow deep breath, and leaning your shoulders back, feeling relaxed and comfortable. Again, the idea is that this will activate our parasympathetic nervous system, which activates our social safety system, which signals, hey, I'm open. Although I'm still in control, I'm open and I'm receptive. So many resources. If there's anything that you saw today that you want some more knowledge on or information on, excuse me, please reach out to me. I will definitely send. Thank you so much.
Thank you, Ronnie. I know I really enjoyed that presentation. I'm sure I can speak for everyone here that we really enjoyed it. We did have a couple of questions roll through, so we'll just get those answered real quick. And if anybody had anything additionally, I provided Ronnie's email in the chat, so feel free to reach out. One of the questions that rolled through, in terms of eating disorders, is there a specific diagnosis that is needed or one that you think would be best to use RO-DBT for in terms of treatment?
Yeah, not a specific disorder. I think the research kind of historically and honestly, maybe a little bit lopsided, has focused a bit more on the anorexia nervosa presentation for a number of reasons. So I would say that that's probably generally the one that RO-DBT kind of caters to the most, but that is definitely not what the newer research is saying. I think that just in general eating disorders, there is a over-controlled presentation, right, with various different diagnoses. So yeah, I'll leave it there.
Perfect, thank you. The other one that rolled in was, in terms of emotional loneliness, how would you measure improvement for RO-DBT?
Good question. So I think that there's a few ways to go about that. For me, it would just be their openness to discuss their emotionality with others, right? So I very often, not very often, there's a couple clients that I have now that when we first started, it wasn't a thought that they would actually express their emotional functioning or emotional suffering with anybody else, right? They kept that alone. They kept it restricted to themselves. So I would say, one way that we can just do it organically, like without any questionnaires or checklists, is to identify, if they are more receptive of expressing how they are feeling emotionally. And one thing that I utilize, it isn't necessarily part of like RO-DBT manual, is just identifying your emotion in the moment. In the moment. I have a client now that basically at the start of every session, we do the emotion wheel, right? And just tell me where you are. So let's start there by identifying it, because far too often we see that because they can become so detached emotionally, it's hard for them to even express where they're at, right? It's a lot of I don't knows, or it's I'm okay, right? Like very, very general, superficial answers. I think you're on mute, Ashley.
My apologies. We did have one more roll through. If you could answer it quickly for us. Would you say being over-controlled is more nature or nurture?
For sake of time, I'll say it's a combination of both. I think it's a true combination of both.
Wonderful, thank you. And just to kind of wrap things up, I just want to extend a thank you to Ronnie for such an insightful presentation and to all of you for sharing the space with us today. We hope to see you all at our next CEU event on the topic of ethics on Friday, April 21st at 9 a.m. This course will count for 3 CEU credits if you would like to register. The registration can be found on all of our social media sites. Thank you all again for sharing the space with us, and I hope you all have a wonderful rest of your day. And thank you again, Ronnie. This was such a great presentation. We enjoyed having you here.
Thank you. I appreciate it.
Have a great day, everybody.